So we can now move to the other award that we are having today, which is the Clinical Biomechanics Award.
Do you want to share any slide, Luca?
Yes, please. So I will be sharing this award together with Dieter Pahr. I see he appeared now. I'm going to share just.
Should have received the invitation.
Yeah. Yeah. Now you should see my. I have just 2 slides actually. So the Clinical Biomechanics Award, for those of you who don't know, it was established quite a few years ago to promote translational research towards clinical problems and not just basic research. The award is given every 2nd year on even years. So here we are. This award is promoted by the journal Clinical Biomechanics, which is edited by Elsevier, who is actually sponsoring this award. So the winner will receive a prize of €1,000, and the winner will also be invited to submit a manuscript to be published as a special article, ESB Clinical Biomechanics Award paper in Clinical Biomechanics. This year we had 11 applications, very nice applications, and also in this case they were first examined by the Congress reviewers when we still thought we were going to be in Milan in these days, and the Clinical Biomechanics Award Committee made then a selection where we have the 4 finalists. So now we will see the 4 papers by the 4 finalists. Again, each speaker has time for speaking, 10 minutes. And I invite anybody in the audience to submit their questions in the questions window on your right. The speaker now is Hans Kainz, and he will talk about botulinum toxin injections do not alter musculoskeletal loading and bone growth in children with cerebral palsy.
Thank you very much. I hope you can see my screen.
Yes, we do.
Perfect. Okay. It's my honor and my pleasure to present my research here today. The title of the presentation slightly changed to Combining Musculoskeletal and Mechanobiological Simulation to Improve Clinical Decision-Making in Children with CP. Before I get started, I'd like to acknowledge our funding sources, my Marie Curie Fellowship, which I finished in March this year, and the SimCP grant, which Ilse Jonkers got. Cerebral palsy CP is a progressive neuromusculoskeletal condition which is caused by non-progressive damage to the motor cortex and or spinal cord. This leads to altered muscle activations, which can in the long run lead to abnormal muscle morphology and bony deformities. And all this leads to walking disabilities, which are one of the most profound disabilities in these children. This project and my presentation today focus on bony deformities, especially at the femur. At the femur, an increased neck shaft angle and an increased anteversion angle are the most common femoral deformities. The neck shaft angle is the angle between the neck and the shaft of the femur, as we can see here in this top figure. And the anteversion angle is the angle between the neck of the femur, if you look at it from the transverse plane, and an axis which is going through the posterior condyles. Children with CP are born with normal bones, but they develop bony deformities during their childhood due to an abnormal loading to the bone. So it can be that in some children with CP, the neck shaft angle and the anteversion angle is increased by up to 40 degrees compared to the typical developing TD children. But this does not happen in all children. So far it is not known which factors actually lead to bony deformities. Hence, our first research question was, what are the reasons for the development of femoral deformities in children with CP? The second research question was, why do not all children with CP develop proximal femoral deformities? Botulinum toxin injections have been shown to decrease spasticity. So they alter muscle activation, they can facilitate muscle stretching, they can increase range of motion, and they might or might not improve gait. So some studies show they improve gait, and some studies show it does not improve gait. So far, however, it is not known if it has any impact on growth. So hence, our third research question was, can botulinum toxin injections be used to stop the development of femoral deformities? A multi-scale modeling workflow can be used to predict femoral growth trends. How does this work? We take our motion capture data from our gait lab, combine it with the musculoskeletal model, and we can calculate the loadings which act on the femur. Then we can collect magnetic resonance images and create a finite element model of the femur by first segmenting the bone and then define specific material properties for certain parts of the bone. Then we can use the loading conditions from our musculoskeletal model and apply it to our finite element model. In a first finite element analysis, we can then determine the growth rate and the direction based on the principal stresses which act on the growth plate. So for each element in the growth plate, we can define a specific growth rate and growth direction. In a second finite element analysis, we can then simulate growth using orthonormal expansion. And then we can compare the final geometry with our original geometry. And as mentioned before, we were mainly interested in changing the neck shaft and anteversion angle. Previous studies so far were limited to a very small sample size with a maximum of 4 participants. They did not include any clinical intervention, and they either used simplified geometries or simplified loading conditions, or they didn't use a model which was consistent between the musculoskeletal and finite element model. And in our latest paper, we showed that this is actually quite important. In this study, we included 6 typical developing TT children and 16 children with CP. We used a child-specific geometry which was consistent between the musculoskeletal model and the finite element model. Furthermore, we investigated a clinical intervention, the impact of Botox on femoral growth. What we can see here is the femoral growth results, so change in anteversion angle on the left side, change in neck shaft angle on the right side, the results for our TT children and for our CP children, and the dashed horizontal lines are the values of the average TT children plus minus 2 standard deviation. What we found is what we expected. Some children with CP were within the normal range, within the TT values, and some of them were outside. What we then did is we divided our CP group in 2 groups. The first one, the CP-TT growth group, so where the simulated growth values were within the typical developing values, and the CP-PAT, for pathological growth group, where the growth values were outside the normal values. To answer the first research question, what are the reasons for the development of femoral deformities in children with CP, we compared our CP pathological growth group with our TT children. It has been shown that hip joint contact forces have the largest impact on femoral growth. Hence, we compared hip joint contact forces and orientation between both groups. But if you look at the equation, how you calculate hip joint contact forces, and considering that the mass and the accelerations of the femur are relatively small during walking, and we can't change gravity, we can also see that the knee joint contact forces and the muscle forces acting on the femur play an important role. Hence, we also included these parameters in our analysis. Furthermore, we looked at the joint kinematics to get a nice overall picture of the whole situation. So what we found was that compared to the TT children, in the CP group with pathological growth, we had in the sagittal plane a decreased hip joint contact force orientation. So what does it mean? We had a less posterior oriented hip joint contact force. Furthermore, we found a decreased posterior hip joint contact force in our CP children during terminal stance. It was likely caused by the decreased anterior pulling muscle forces during terminal stance. And this is likely due to a missing hip extension during the terminal stance, which we can see here. Furthermore, we found increased knee joint contact forces in initial contact, which was likely caused by an increased knee flexion angle during this part of the gait cycle. Our second research question was, why do not all children with CP develop proximal femoral deformities? To answer this research question, we compared our CP group, which had pathological growth, with our CP group, which had typical developing growth. What we found was quite interesting. So the sagittal plane kinematics did not differ between both groups. But what we found was that in the CP-TT growth group, these children used a different pelvic and hip movement strategy during mid-stance. I tried to visualize it here. So in the group with TT growth, the pelvis was up and the hip was adducted, while in the group with pathological growth, the hip was down and the pelvis was down and the hip was abducted. So it seems like this different hip and pelvis movement strategy leads to an increased hip joint contact forces in our CP-TT growth group, and this leads to a normalization of the hip joint contact force in the sagittal plane and therefore leads to normal growth values. Our last research question was, if botulinum toxin injections can stop the development of femoral deformities. For this research question, we analyzed a subset of our CB participants. So we had 8 CB children where we had pre and post Botox motion capture data. And what we found was that it didn't change the hip joint contact force. Hence, it also didn't change the hip joint contact force orientation, as we can see here in sagittal plane. But what we can see here that some of the participants were already within the normal range. Hence, not surprisingly, it did also not change the femoral growth results, and some of the children were already within the normal range. So to sum it up, what is the take-home message? We showed that the hip joint contact force orientation, especially in the sagittal plane, has a major impact on femoral growth. Hence, it's really important to get the hip joint contact force orientation correct in these children. Furthermore, we showed that missing hip extension in the terminal stance is likely one of the major reasons for femoral deformities in children with CB. And this is in line with the assumption from some clinicians, with the assumptions which some of the clinicians already had. Furthermore, within the CB children, we saw that a different pelvic and hip movement strategy can normalize the hip joint contact force orientation and therefore lead to a normalized femoral growth. And this different pelvic and hip movement strategy has been already observed in children with CB who had a subluxation of the hip. Furthermore, we showed that Botox has no impact on femoral growth, and this is in line with the studies which showed that Botox did not change the walking pattern of the child, and if it doesn't change the gait of the child, it is not surprising that it doesn't have an impact on the hip joint contact forces and therefore also not on femoral growth. But more importantly, I hope I could show you with this presentation that this multi-scale modeling workflow has the potential to pinpoint certain CB characteristics within this whole complex CB pathology, which are likely to lead to bony deformities. And I think this has a huge potential because if we can define certain clinical interventions early enough, which normalize the hip joint contact force orientation, we might be able to avoid the development of femoral deformities in children with CB. The next step, so in the overall big picture of this project, is to validate some of these modeling assumptions. And I'm quite excited because I just employed my first PhD student, and his main task will be the validation of this workflow and to move this project forward. Thank you very much for your attention, and I'm more than happy to answer any question.
So thank you, Hans. So as we agreed with Luca, I will take over the question and answer session. And there are already the first question popping up. And the first question is going to your last words about how you plan to validate your workflow and how you think that you can bring this into clinical practice.
So the plan for my PhD student is to actually collect magnetic resonance images on 2 time points. So once like very soon now, and then again in 2 years. So then we would have really longitudinal data where we can then really compare our modeling results with the actual growth results. So within, I didn't have time to really go into details, but within this workflow, there are certain modeling parameters which are based on certain assumptions, and some of them have been based on literature, which have been kind of validated with some experiments. But for example, the growth direction, it's not really well known in which growth direction to model growth. So this would be some of the assumptions which we would like to validate in the future. The second question was about the
how you think to bring this into clinical practice.
So the first step will be to validate the workflow, and the second step to get it into clinical practice. One of the problems is also this workflow at the moment. If you create a finite element model for each patient, it takes a lot of time. So first of all, we have to figure out how accurate it is, and then if we want to go to a patient basis, a patient-specific basis, we first have to figure out what parameters do we actually need to get accurate results. Because for a clinician, it doesn't really matter if it's 0.1 degree more or less. They want to know, does it improve, does it not improve? And for that, if we know which parameters we have to include to get accurate results, we can then basically try to limit the details to still get accurate result. And for example, to use, instead of creating a finite element model from 0, we could maybe also use a parametric femur to speed up this whole workflow.
Okay, so there is a further question which asks how you divide these 2 pathological groups. So what was the criteria? What was the criteria for dividing this pathological group into these 2 groups? Right, we has the these two groups with the PD growth and the path growth group. Yeah, here the green and the red. So how did you divide these two groups?
So basically, if either the change in anteversion angle or the neck shaft angle was within the two standard deviation, if it was both was within, then it was in the CP-TD growth group. And if one of these parameters was outside, it was in the pathological growth group. So now it looks like, for example, this participant here should be in this group, but this participant here probably was outside in the anteversion angle. So if one of the parameters was outside the two standard deviations of the typical developing children, then we considered them in the pathological group. If both parameters were within, we considered them in the TD growth group.
Okay, final question. Thank you, Hans. How did you model this PTX injection?
Sorry?
The question was, how do you model the PTX injection? I think you...
The direction here, so I have a final slide, a bonus slide. So basically, there are different approaches. We used, the growth direction was modeled in the average deflection of the femoral head.
I think the question is different. The question is about how you model the effect of the botulinum injection.
So basically, in this case, we only use the motion capture data. And so basically, they are like always, it's always the question, do you include the change in the muscles in your musculoskeletal model or not? In this case, we did. So basically, we used the EMG informed approach, so it's kind of indirectly integrated, but already the change in the walking pattern actually covers indirectly the change in the muscles. So we used the musculoskeletal model, which was taped to the participants, which included the EMG activations, but we did not modify specific muscle parameters in our musculoskeletal model, because it is actually, so far from what I know, it's very difficult to pinpoint which parameters you actually have to change to get reliable results.
Okay, so thank you, Hans, for this interesting presentation, and I'd like to hand over to Luca.
Yeah, thank you, Hans, also for being available to start earlier. Let's try again with Ingmar. Now that you logged out and in, probably you should be able to do it, and otherwise we have a backup plan.
Okay. So now I'm ready. So thank you very much for the introduction. Sorry for the technical difficulties. It's an honor to present in this session today. And I would like to talk about hip fracture risk assessment in my presentation. Hip fractures, as many of you know, are a common injury in the elderly population, especially in women, and they're associated with a higher socioeconomic burden and severe consequences for the individual, namely a high risk of walking impairments and a high risk of mortality after the fracture. The leading cause of hip fractures are falls from standing height or lower, as shown in the images here on the right, which show image footage from a Canadian care facility, and these are falls that actually resulted in hip fractures. But who's at risk of fracturing? Clinically, this question is addressed by doing dual energy X-ray absorptiometry, which is used to derive an aerial bone mineral density, short ABMD. This metric has been shown to correlate to ex vivo femoral strength. However, it has also been shown in population-based studies that the metric lacks sensitivity and it lacks specificity. As an alternative, CT-based finite element models have been proposed for subject-specific femoral strength assessment. These femoral strength estimates have been shown to correlate better to ex vivo femoral strength than ABMD. There have been also indications in cohorts based on post-fracture imaging in female subjects that the classification accuracy for hip fractures could be improved based on femoral strength. However, there has been no study so far that used baseline information and follow-up fracture registry and conclusively showed increased characteristics for hip fracture risk assessment. In this study, we used the AGES Reykjavik study cohort, which is a cohort that consists of 4,800 Icelandic men and women above the age of 65. The cohort contains calibrated CT scans with a 5 to 7 year fracture follow-up. And we subsampled a cohort cohort design of 610 subjects, 9 of which failed during model creation. So we had 601 subjects with 201 fractures included. Of these subjects, 362 were female and 239 were male subjects. Our modeling pipeline then looked as followed. We used Python, MITK Gem, and ANSA to first segment models from CT scans, remesh the models, and then apply bone mineral density heterogeneously over the femur. The models were then transferred to ETH, where the model generation process was blinded to the fracture outcome. And coordinate system was created for landmarks, and 12 loading alignments were simulated for each femur, 3 adduction angles and 4 internal rotation angles. We then applied nonlinear boundary conditions that featured frictionless contacts at the femoral head and greater trochanter and a hinge joint at the knee. The force was then applied through a prescribed displacement at the femoral head boundary condition. The models were solved in LS-DYNA and then automatically evaluated using Python scripts. The material model that we applied to these models was a nonlinear strain rate dependent material model that was validated by Ensper et al. In 2018. And based on the results of these simulations, we decided to also implement 2 reduced material models, one that did not feature the strain rate dependency of the material, but was still nonlinear. And these 2 materials were evaluated by evaluating the peak force in the force displacement characteristic of the given femur. We also implemented a linear material model that followed a procedure published by Kasim et al., where the femoral fracture force was estimated based on the surface strains and the force thresholds that was simulated. We then processed the data to investigate the influence of internal rotation and adduction angles on the femoral strength prediction, and we furthermore investigated the hip fracture risk assessment capabilities of the different metrics with the area under receiver operating characteristics curve. And statistical differences between AUC metrics were established based on non-parametric bootstrapping, also using a Benjamini-Hochberg correction procedure for multiple hypotheses. The influence of loading alignment, as you can see in these 3 graphs for the 3 different models, showed that increased adduction and increased internal rotation resulted in a reduction of femoral forces, and this was consistent over the 3 models and was found to be statistically significant. The different models in general behaved very similar. However, the nonlinear material model without strain rate dependency showed a somewhat lower sensitivity to the loading alignments than the other 2 models. Looking at the predictors for hip fracture risk, we can see in this table here, which shows AUC values for the different predictors, and these are the best predictors for the individual models. We can see that the nonlinear models showed a significant increase in AUC compared to aerial bone mineral density for female and for male subjects. However, the linear models did not reach significance when compared to aerial bone mineral density. For male subjects, the nonlinear models for the best alignment also were more significant compared to the linear models with best alignment. Looking at an example rock curve here for the nonlinear material model shown in orange compared to ABMD in black, you can appreciate that the FE metric was better over the whole range of the rock curve and not just in parts of the curve. Now, looking at a specific threshold to evaluate how much can be gained by such a metric, we analyzed the false positive rate of female subject at the osteoporosis threshold, resulting in a false positive rate of 0.314. And we used these thresholds to analyze the true positive rate for the different metrics. This resulted in a 10% increased identification of fracture cases for the nonlinear model in females and a 23% increase in male subjects. So how does this compare to studies that have published previously? There have been a number of studies on cohorts, and here we've split them into studies that use baseline information and a fracture follow-up at the top, and studies that use post-fracture imaging with a control group at the bottom. Our study that we present here belongs to the former category. If we now remove the studies that did not report any increased AUC, we can nicely appreciate that most of the studies that reported an increased AUC use tetrahedral elements in their models and a smooth surface. We can also appreciate that the post-fracture imaging cohorts used only female subjects, and these cohorts have in general shown a higher increase in the AUC prediction so far. They also used a rather lower sample size compared to the baseline predictor cohorts with fracture follow-up. And we can see that our study is the only one that tested for statistical significance in the AUC and achieved it. So in conclusion, the fine element-based strength was dependent on the internal rotation and the adduction angle, with the lowest femoral strength typically in the highest adduction and highest internal rotation angle. This is the first study to show a significantly improved AUC value compared to ABMD in the HS Reykjavik cohort. And our nonlinear material models performed better at classifying hip fracture risk than our linear material model, and this was only significant for male subjects. In the future, we think that this methodology should be evaluated in multiple cohorts, and we also think it could be useful for opportunistic screening based on abdominal scans that were taken for other purposes. Furthermore, the FE models could be used to evaluate the subject-specific treatment selection and treatment development for the individual treatment selection. With this, I would like to thank my collaborators at the EGH in Zurich. I would like to thank my collaborators at the University in Iceland and the Icelandic Heart Association. I would like to thank all of you for your attention, and I would like to acknowledge my funding source. I'm happy to receive any questions.
Oh, thank you for this. Thank you for the presentation. First question which pops up, the model of end spray was validated with one loading direction, but you are suggesting another model, another nonlinear model, and this nonlinear model is including various loading directions. So how did you validate this model, or is it simply now a numerical model which is not validated?
So the validation, of course, is only for this one single alignment that was tested experimentally, and that's what the material model is validated for. For now, I have not seen experimental studies that allow for the validation in multiple alignments, and this would be a very interesting thing to do in the future. So I think it would be very beneficial for the field to see if these differences in loading in strength with the different loading alignments actually hold true if you tested a large number of femurs under different loading alignments that represent a fall. Okay. For this model, yes, it's not validated in other alignments.
Waiting for the next question. In between, I'm asking a question. So you talked about hip fracture predictor. So how was this exactly defined, this hip fracture predictor?
Well, the different metrics to predict the risk of hip fracture or predict the hip fracture in this cohort were the femoral strength metrics that were extracted. So that's the maximum femur force in the force displacement characteristic for the nonlinear material models, or this extrapolated femoral strength for the linear model. And here it's
a force threshold, if I get it right. So you have different force thresholds for the women and for the men, right?
For the single false positive rate that we evaluated in the results, yes, that was a single force threshold for the individual models and separate for women and men.
Mm-hmm. Okay. So there is a further question here. Where should the risk of all of a fall appear in this picture? So
if the risk of falling basically should be in this picture. Of course, this is not included in the current study, so we focus purely on femoral strength itself, which is one aspect of the risk of suffering a hip fracture. If we knew the risk of falling for the individual, we assume that this would improve the hip fracture risk assessment.
Okay. And there is a follow-up question. So now you're using a white box model to predict your strengths and to do these ROC curves, but how about machine learning? So could you imagine, because of your huge amount of data, that even there is no need of a finite element model, that you can do this simply by machine learning?
Yes, we had that thought. So far, we have not set up anything in that direction, but in theory, I could imagine that you could use the CT scans and patient parameters directly in a machine learning approach.
Okay. So thank you for your presentation. And we are moving on to the next one. Please, Luca.
Yep. Thank you, Ingmar. And we go to the third speaker, Luigi Barbera. This paper is about in silico patient-specific optimization of correction strategies for thoracic adolescent idiopathic scoliosis.
Thank you for your introduction, Luca. It's really a pleasure and an honor to be here today with you. So, adolescent idiopathic scoliosis is a multifactorial pathology of the spine affecting 1 every 20 adolescents, mainly girls, leading to a typical three-dimensional spine deformity. This can be easily appreciated using the planar standing radiographs and reconstruction techniques, which allows today for a very precise quantification and appreciation of the three-dimensionality of scoliosis on all three anatomical planes. The co-angle is traditionally the most relevant parameters to monitor over time. If it progresses above 45 degrees, then a posterior surgery is recommended. The decision-making process to define how the surgery is to be performed starts with definition of so-called correction objectives, where the surgeon has to define which anatomical plane to prioritize in terms of correction, which deformity indices to address across the surgery, and also how many levels are to be fused, given the spinal stiffness of the specific patient. Of course, corrections can be achieved intraoperatively, applying a variety of techniques, which consist basically in applying displacement, rotation, or forces and torques in order to bring back the spine to the desired position. The capability of several correction maneuver to address specific correction on the desired anatomical plane relies also on the position of the anchor points available in the spine, mainly the position of the rod, of the implants, their distribution, the number, but also the spinal rod shape, which is often used to guide the correction and to keep it fixed. Of course, these three concepts, correction objective, maneuvers, and instrumentation parameters, are significantly correlated one with each other in a very complex ways. And today there is no consensus on how to perform the best strategy, even for the simplest scoliotic curve. So that also correction objective, those which are to target, are also heavily debated in the clinics. Having in silico intraoperative models, therefore, is very advantageous for three main reasons. First of all, to understand the biomechanical principle of 3D deformity correction, then to assist the surgeon in the decision-making process, but mainly and finally also to optimize the correction strategies on the real patient needs. While the first 2 points have been already thoroughly investigated by my group in Montreal, developing the so-called spine surgery simulator, the third point will be the topic of the present study. The objective was to develop and test an in silico patient-specific surgery planning algorithm capable to identify the optimal instrumentation strategy for a simple thoracic scoliosis. The workflow typically starts with the reconstruction of the patient's spine. Here we have a typical thoracic scoliosis with just one curvature. We measured the preoperative deformity indexes thanks to the 3D reconstruction. We personalized the material properties of the anterior spine, calibrating its property based on lateral inflection tests. Then we defined a script defining 5 instrumentation parameters, in particular different screw pattern growing from a very low density up to very high density bilateral construct. The instrumentation length can be easily defined playing with the upper and lowest instrumented vertebrae that in our study have been defined according to the recommendation of an experienced surgeon. We also played with the concave and the convex rod curvature, either combining different curvature on keeping the same differential between concave and convex rods, or even increasing it across several configurations. And moreover, we were also interested to test several rod contours, increasing both rod contours at the same time. Rod stiffness was also an additional parameter accounted inside the script. We defined adequate correction maneuver. Just to better understand how it works, here an example. For this specific set of instrumentation parameters, we defined adequate boundary condition. The main correction strategies that have been simulated here are concave rod derotation, presented in this step, followed by en bloc derotation. After positioning of the convex rod, then the simulation is capable to predict the post-operative indexes and the number of used levels. We performed a full factorial design running up to 1080 simulation. The prediction of the simulation was passed to a post-processing step where we defined an objective function, which was minimized in order to determine the optimal correction strategy. To better understand how it works here, a more detailed explanation. The objective function consists of 4 terms, 3 for each anatomical planes on the coronal, sagittal, and transverse plane, taking into account for the post-operative values calculated with the simulation and compared with the pre-operative reconstructed values. The 4th term, mobility, simply accounts for the number of used vertebrae. In front of each quadratic term, there are some weight factors which can be specified in order to define the relative importance of each term. And they can be defined depending on the surgeon preference. And they are the so-called correction objectives. In order to better understand how these weight factors affect the objective function output, we performed a very detailed sensitivity analysis, testing 55 possible combinations, where in each column you have the 4 possible combination of weight factors. Either we assumed a systematic sampling, really spanning across all possible combinations, and we took also values from the literature. To better understand this, here an example. If we take this specific set of weight factors, then we can easily calculate the cumulative distribution for the objective function output. And upon minimization, we can identify, in this case, a unique optimum with its own specificity descriptors and instrumentation parameters. If we pick another set of correction objectives, we notice also that in some cases the cumulative distribution could have a flat minimal region corresponding to multiple optima. But also in this case, the algorithm was capable to provide us numbers relating to the 3D descriptor and a statistic on the instrumentation parameters. As you understood, across the 55 correction objectives that we tested, we found only 10 unique and 3 multiple optimal correction strategies, and only 11 unique and 1 multiple worst case strategy. We statistically compared the results between these 2 groups and found significantly better correction in the coronal plane and in the transverse plane. Regarding instrumentation parameters, we got a significantly higher implant density, which is defined as the number of screws over the instrumented vertebrae, only at the convex side. In order to better understand how the optimal strategy are related to specific instrumentation parameters, we performed a factorial ANOVA which demonstrated that the coronal correction was mainly significantly affected by the LIV. And this can be easily appreciated on this slide, simply noticing that having a more distal LIV on L3 allows to better correct the coronal plane, while a worse correction can be achieved with a more cranial LIV. Regarding the thoracic kyphosis, it was mainly affected by rod curvature, and this can be easily appreciated having a differentially contoured rod which was able to restore the kyphosis to the normal range, in between 20 and 40 degrees. But when combining rod curvature with the upper instrumented vertebra, we also noticed that a high curvature and a more cranial upper instrumented vertebra was leading to an even higher sagittal profile. Apical vertebra rotation were affected by all the factors, but to a minor extent. We decided to review all these optimal strategies together with the experienced surgeon participating in our study, who suggested to remove those correction strategies associated with an unsatisfactory correction, here highlighted, and also those strategies which are associated with a very long instrumentation. Therefore, after the review of the experienced surgeon, we ended up with 4 optimal correction strategies. We repeated the statistical analysis, and we found even better, even higher significant correction on the Cobb angle, and no difference between optimal after review and worst case scenarios in terms of implant density. We saw that the decreased implant density was bringing back the optimal configuration in the low density range. That may suggest the idea that only using high density pattern may not be necessary, and we could spare some screws in order to achieve an optimal correction. Coming to the conclusion, we demonstrated that an in silico optimization algorithm accounting for 2D correction and mobility was coupled with a patient-specific thoracic scoliosis model. We found that multiple correction strategies are possible, and they strictly depend on the correction objective that we select. We found that the algorithm was able to determine significantly higher correction for the optimal strategies, both in the coronal and in the transverse plane. And this correction was significantly related with specific instrumentation parameters. The surgeon review steps was very beneficial in order to ensure the acceptability and the feasibility of the optimal strategies, and was making the overall algorithm even more significant, specifically on the coronal plane. Future step could be to include in our future study more patients to increase the impact of the present work, to analyze not only simple thoracic scoliotic curve, but also double curves. Probably would be also interesting to add in the objective function also intraoperative loads. That's something that the model can appreciate already. And the long term is also to integrate the algorithm presented in the present paper in a prospective clinical study. With that, I would like to thank my co-author, my funding body, and I would be happy to answer any questions.
Okay, so thank you for the presentation. So let me start with the first question. So if I'm thinking about a clinical applicability, so
yes,
first of all, what would be needed as input for your model? And second, how do you make sure that the surgeon is able to do exactly that what you predict in your in silico model?
Yeah, that's a very interesting question. Thank you. I think that the main point here is that inside the simulation, we are prescribing several steps which are very complex. And there we are assuming several boundary conditions which somehow may look a bit, let's say, arbitrary. The power of using simulation is that we can perform a thorough sensitivity analysis on these input factors in order to understand which of them are those who are most important to control over the surgery, and to make sure that we can measure them during the surgery. So another second point would be to use navigation in order to make sure that these few input parameters that we use for the simulation are really reflected in the reality in the surgery room. And that would be beneficial.
To have like a check that what you predicted in a further study and see what is really the outcome. Another question in this direction is here, how do you assess actually the intervertebral disc stiffness? Because it's an important input parameter, and it's the most flexible part in your whole model. So how do you think that you can assess this on a specific patient prior to a surgery?
Yeah, this is something that I skipped because it's something established from previous colleague in Montreal. But basically, the second step the second step, where we personalize the intervertebral stiffness and calibrate it. Basically, we take values from available from the literature from cadaveric spines. They are divided for the thoracic segment, for the lumbar segment, and we simply rescale this factor, just taking into account for the lateral flexibility that the patient can demonstrate on standing radiograph, but with lateral bending.
Yeah, maybe you're thinking about taking into account the variance of these parameters, because it seems that it's quite some range you can have, and it's not a simple scaling. You have a uncertainty in it.
Yeah, for sure. This is one of these input parameters that would be relevant to study. Maybe performing a separate sensitivity analysis in order to understand whether or not we are able to calibrate really exactly the same mechanical properties that we see on the lateral bending radiographs, or either to account for possible inaccuracy in the calibration part.
One further question here: how long does it take to run such an analysis on a patient? So having all the inputs given, so how long does it take till you get an outcome?
So one simulation runs in 1 to 2 minutes, depending on the length of the instrumentation. Let's say a short instrumentation, like the one you see here, takes 1.5 minutes. A very long instrumentation may take 2.5 minutes. The full set of 1,000 simulation.
You have all your variances for the optimization. So that the whole optimization thing. So how long is, so one for 1 to 2 minutes, and the whole thing?
Computation times running every possible combination without any smarter sampling methods could run in 36 hours. The post-processing part with the optimization in a few minutes.
Okay. So thank you. We should move on to the next speaker and then hand over to Luca.
Yeah, thank you, Luigi. And so the last speaker of this session is Marzieh Ovesy, explicit finite element simulation of uncemented total hip arthroplasty, implant insertion and loading.
So thank you for the introduction, and it's an honor to be a part of this session, and good afternoon to everybody here. So as mentioned, I'm going to talk about the total hip arthroplasty and the uncemented case and use of finite element simulation in this prediction. So the operation consists of removing the head of the intact femur, and then using a process called broaching. The surgeon opens a canal into the femur with a device called rasp that is smaller in size than the real implant. Then the implant is hammered into the femur using a press-fit configuration. The surgery is quite successful. However, 2 to 10% suffer from the fact called aseptic loosening. So this means the loosening of the implant in the absence of infection disease and new fractures, and would end up to the need of revision surgery. So the way it's assessed is usually through primary stability, that either it's quantified by the force that the surgeon needs to position the implant in its final configuration. And the idea is that it might occur that the more force you put, the better the implant is stabilized. However, you have to mind that you would not end up to femur fracture. The other term is micromotions, that these are the relative motions between the bone and implant after the system has gone through loading. This should be in a certain range in order to trigger the osseointegration and prevent loosening happening there. So the assessment techniques used are either experimental techniques that suffer from the fact that a sample could be used just one time, or you have less data points for extraction of micromotions. The other approaches are finite element simulations that they have not investigated so far precisely what the damage at the interface is, either by assuming no damage at the interface after the implantation or assuming a constant damage everywhere. But we know that the real case is not that, and the damage changes throughout different positions and different DVTV of bone around. So accordingly, the aim of this study is to predict the primary stability in terms of implantation force and micromotions, including the effect of damage at the implantation stage and its variation. For that, we developed the computational framework to account for the implantation stage, and also we would be able to explore the influence of implantation press width and bone damage on the primary stability. For our model preparation, the 3D femur was constructed from the CT data. The head was removed, and in order to resemble the broaching effect that I previously mentioned, we shrinked the implant in all directions, once with 0.92 millimeter and once with double the size, 1.82 millimeter. And we then subtracted these two masks from our femurs and ended up to the low and high press width configuration that you see here. And we would use this open canal later for our simulations. So here our model is a density-based model, and we have a continuum damage model that is based on the plastic strain into the element. And as you could see here, when the element is highly damaged, the element is deleted. The advantage is that it doesn't occur, like you don't have convergence issues as the highly distorted elements are deleted here. Then at the interface for our contact model, we had normal contact with tangential contact with 0.3 of friction based on the data in the literature. So for our implantation boundary condition, we assumed our reference node of the implant to be at its bottom. However, in the real case, it's at its top, so the surgeon applies the load here. But in order to simulate the implantation process, we were able to do it when we got the reference node here. Then we pull the implant inside the canal only in one direction of Z and leave the other directions of 5, the other degrees of freedom free, so that the implant could self-position itself inside. So as you could see here, the position of the reference node reaches a final UZ, and then we let it free to reach the 0 force at the end of the implantation stage. So here you would see the results of our implantation, low press width blue, high press width red, and you see how the damage changes the path of the implant for those two cases and how the implant is positioning itself inside the bone. On the right side, you also see the changes of the force curve and how it's changing throughout the displacement for this implantation stage. So here for our force curve, you see that the maximum force achieved for the high press width is around 4 kilonewton higher for low press width. And the data fits well with the range reported in the literature. And also you see some oscillations in the curve of the force, and that is mainly due to element deletion or the different contacts of implant with different bone densities around. One could also look at the stress distribution around the implant, and at the implantation stage, one could check that if any point around the implant has entered its fracture zone or not. And the other thing that is interesting is the damage contour around the implant. And you also could see the deleted elements in black. And we see that for the red, that it's high press width, we have more deleted elements. Then right now we are at the end of our implantation stage, so naturally the bone around has been damaged and we want to apply the loading here. So we chose one cycle of a walking gait cycle from orthoload data team and applied the 3 force and 3 moment components on the reference node of the implant and let the bottom surface to be fixed in the 3 directions. So what's important is how we extracted the micromotion. So we look at different stages of time throughout our cycle. We find the closest node between the bone and implant and then extract the position vector between these 2 nodes. Then we go to the final configuration. We choose the same 2 nodes that we had before and again get the position vector between these 2 nodes. And our micromotions would be the subtraction of these 2 vectors. Here, I'm going to talk about the irreversible micromotion. So on the right side, here you see what forces and moments we have applied to our model. Here we see the T current for us is at the beginning of our cycle and T final is at the end. So both are the unloaded configurations. So the micromotions we get here are the plastic ones. In the other word, they are the irreversible micromotions, meaning that by the end of cycle, these motions are existing in our bone. each point, colorful point that you see here, is representing the R1 minus R2 for each one of these points around the implant. You see that for low and high press width, we have different values, and also the localization is different. And we have extracted between 300 to 400 points around the implant. That is much more than the existing experimental data that has been reported in the literature. So here we use the same approach, and we made a video for the low and high press width for just 10 points throughout this cycle. More points could be extracted, but we just extracted here 10 different points throughout the time. And the advantage is that one could really track one point and see how the micromotions are changing throughout the time. And the values range from 0 to 0.8 millimeter. If you look at the data in the literature, you also see that it's a vast range, but this could mostly come because there are different boundary conditions, sometimes also muscle forces applied, and also different modeling techniques applied here. So, but the whole idea in this slide is that our ranges are fitting the range reported in literature. Maybe it's not because we don't have any experiments for this case, but the range is fitting, and that's what we wanted to show here. Then to come with a summary of what we did, we developed a computational framework for the primary stability. In order to achieve that, the implant insertion was done for a BVT variation and also press width variation into the femur. Then we saw that the implant is self-positioning itself inside the bone, and based on the damage distribution, and also one could see what's the damage, what's the force of implantation, and what's the stress distribution. Our whole data matched well with the reporting values in the literature by the experimental cases. And after that, after the femur was well influenced with the damage, we applied a realistic loading that was force controlled instead of the currently existing displacement controlled protocols that are different from the real physiological case, and looked at the micromotions happening around the implant. And then we also looked at the differences for the micromotions between high and low press width, and also saw that our data fits well with the literature data. There is one of the limitations of my work is that the whole work is mostly showing what is achievable throughout this computational framework, and we didn't have an experimental validation for that, but it needs a good experimental validation. And if that is done for a take-home message, this computational framework could be extended later to various orthopedic or dental applications. For that, I would like to say what is the future potential of the study. So in case you, after it's validated properly, you could have the CT scan of the bone, the implant CAD, and then the clinicians could use it to come with patient-specific protocols, and the industry could use it to come with a better implant design. These both would decrease the number of experiments needed and save time and money. With that, I would like to thank all my group members and all my funding sources and all the other people that have helped me throughout the project. And I would be happy to answer to any questions.
So thank you for the talk, and we are ready for the questions. So the first question is, now you developed this model, and if you intend to use this model for a larger group, for a larger cohort, do you think this is possible?
So currently our models are a bit time consuming, so that's also a limitation. So around 24 hours it takes that we have the results. But one could also start to work a bit and try to automate some parts of this modeling, for instance, the model generation, because here we just did 2. And the more you do it automized, I think it would be possible in early future to have it for real applications.
Roughly speaking, how long does it take to analyze one model?
Roughly 1.5 days from the preparation to analyzing, whenever we have just one cycle. Here we have one cycle.
And this comes to the second question. So you already have your implantation process, and the question is, if you start having a loading cycle on it and you on-go with the loading cycle, so how does this change the micromotion? Did you check this, or did you go into this if you're repeating this loading cycle again and again and again and again?
So the point is, we have done that for a single load, so a single point cycle, and it changes, but it starts to reduce. So the irreversible micromotions start to reduce after the third cycle. But for a gate cycle, since we wanted to really apply it with the gate, we didn't do more than one cycle, but it would change. It would change, but our estimation is that after the damage has achieved, we would see that it would stop, or not stop, like the irreversible would get lower. Okay.
Then a further question is by explicit FEA. So what are the benefits and pitfalls of this method compared to the classical implicit finite element method?
So this is the point that I mentioned here. When you have the element deletion technique, when I would show it. So here, when the implicit models just get the bone when it's damaged, and it would remain into the model, but then it would bring up convergence issues, and here we have a lot of deformation. The advantage of this model is that when we have reached the maximum level of damage, the element gets deleted. So this is the advantage of the explicit model that we have used here.
And the pitfall, or is there no pitfall?
Pitfall is always the time compared to implicit here. So usually the time is much higher. That's always the case. And also with the element deletion, as I mentioned, you have oscillations in your response.
Okay. Then there's a final question here. If you use clinical CT scans and you probably overestimate the cortical thickness because of the scanning technique, how do you think will this affect your final results? Is there an effect based on clinical imaging, brushing volume effects, and all these problems, or not?
So we didn't look much at, let's say, imaging techniques. So the idea of the model is that you get the CT data, and we didn't put much time in the segmentation. So it's like all the elements are based on the BBTV values that you observe here. So this makes it a bit easier. And also when you see like the marrow in the bone, we have put like with very small stiffness and reduce the effort for the clinicians that they need to segment the canal in. So I would say with our technique, it would not change much, because we are anyway looking at, we don't separate the cortical thickness here. It's just based on BB.
Thank you. So I also see there is a very active colleague who asking many questions. So sorry, we don't have the time, so please directly connect.
Sorry, just to mention, yes, I have put my email here in case anybody wants to have further questions. I would be happy to answer.
Okay. So thank you for the talk and the discussion. And finally, I'm also handing over to Luca. Luca, please.
Yeah, it is very good. Thank you, Dieter. It is very good to see that there was some interaction, even if we are sitting thousands or at least hundreds of kilometers away. So it was a good interaction in all the sessions. And I would like to thank all the speakers for having supported this tool, and also all the attendees. We were nearly 200 at some point. So it was, I think, quite a success, and everything worked smoothly thanks to Enrico and his fabulous student team. Before closing this session, I would like to remind you that we are still having the elections for the council positions. Today is the last day, so if you are a member in good standing and you have not voted yet, please go online and vote for the new members of the council. Apart from this, thanks for attending, and we will see you tomorrow again on the same GoToWebinar system for the Best Doctoral Award and for the special announcements. I'm not sure if Enrico needs to say anything else before we close.
No, I mean, I'm just thanking again every speaker and everyone from the audience for the active discussion. Just remember that if you want to attend tomorrow, you need to register also for tomorrow's session, which has a different link. And that's it.
Okay. Thank you. Bye-bye, everybody. See you tomorrow.
Bye-bye.
Yep, bye.